Unfortunately, the outcomes for early stage lung cancer are very poor. In contrast to other solid tumors such as breast cancer and colon cancer, stage 1A patients, for example, have a 5-year survival of upwards of 95%. But for lung cancer, these 5-year survivals are 60–70% routinely. So something's really needed to help these early stage lung cancer patients. And one of the effective therapies that we've seen in later stage patients is adjuvant chemotherapy. Now, the trials of adjuvant chemotherapy in stage 1 patients have not been as successful. And we think that's partly due to the reason that you're treating the low-risk patients that are stage 1 and as well as the high-risk patients who are stage 1. So the toxicity experienced by the low-risk stage 1 patients actually mask the benefit from high-risk patients. So one of the immediate goals of this assay is to help identify those low and high-risk patients from each other so that effective chemotherapy can be given to the right stage 1 cohort. It's the largest trial reported to date with the most number of specimens both in the training and the 2 validation cohorts. And a very important aspect of our study was that it was blinded. So one thing that can be done when you develop a prognostic test is that you just keep tweaking it so that it performs well in both your training and your validation cohort. And instead, we took a truly blinded approach. It was a one-shot, it was a one-shot approach, and we developed this assay, and we said, okay, we're done with it. We validated it, internally in analytical validation, and now we're going to see whether it validates clinically. So we conducted this trial on these 2 large patient cohorts, and we believe the strength of those results show that it's ready for prime time. And so the real controversy, I think, in early stage lung cancer is 1 to 2A patients, potentially 2B patients as well. And so the hope is that by identifying high-risk stage 1 patients, you're going to improve their survival by giving them adjuvant chemotherapy. And similarly, in stage 2 patients, you can avoid some of the toxicities of giving adjuvant chemotherapy in those very low-risk stage 2 patients. One of the strategies we developed early on was to develop this in conjunction with a CLIA certified laboratory, and that gave us the hope that something like this could be rapidly adopted for clinical practice. And that's also one of the reasons we made it so practical. It's a qPCR-based assay using paraffin tissues, and really following the lead from some of the work that's been done in breast oncology, where there's a similar assay available for breast oncology. But to date, nothing has been available for lung cancer until now. So the assay can actually be ordered through this company that helped us develop the assay. And we think that the addition of prognostic information, even to patients, to tell them whether they're low, intermediate, or high risk for stage 1 right now is extremely valuable. And with the future hope that conducting a prospective randomized clinical trial will truly show benefit for these high-risk patients as well.